All right, we'll get started. Did you get the record?
I know, because it wasn't that I did.
All right. All right. It's a little finicky here. Let me get it going. So we're going to have a quick review of the parts of Medicare, just brief, quick review, so that some of the items that come up later will have some context to Part A or Part C or Part D. So the parts of Medicare, we have Part A and B and D and C. And Medicare has divided it up so that original Medicare is called Part A and Part B. And it's when a person uses their red, white, and blue card for their medical services. They call that original Medicare. When someone has original Medicare, they can have drug coverage through Part D, a standalone drug plan. It would be a Part D plan. And they also have the option of adding Medigap coverage. So I'm going to address those topics in a little more depth in a moment. The other way of using your Medicare comes under what they call Part C, more commonly called a Medicare Advantage plan, which is a bundled combination of Part A and B, and usually the D for drug. So we'll be talking more depth in a minute on every one of these. Starting with the Part D. So drug plans are approved by Medicare, but they're run by private companies. And a lot of times when I talk to people who are newly coming onto their Medicare, they kind of expect their Part D to get added to their red, white, and blue card, and it never does. Part D is always a separate add-on plan that you have to take action to enroll. And it's a private company. You might be enrolling in a company like Humana or Aetna or United Healthcare. There's quite a few of them. In fact, there are 24 Part D plans in the state of Virginia for next year. And they're all approved by Medicare and have a contract in the state in which they're going to operate. Anyone that has Medicare is eligible to sign up for a Part D plan. And in fact, Medicare rather expects people to sign up for a Part D plan. A lot of us are in the know that Medicare has a penalty for those who don't sign up. And it's called a late enrollment penalty. And it has to do with the number of years or months that a person went without Part D when they were eligible for Medicare and had no other drug coverage, like through an employer or the Veterans Administration. So if they had no other drug coverage, there could be a penalty that's based on the number of months or years that they were without that drug coverage, and it's assigned to them for the rest of their life. So a way to avoid the penalty is taking the Part D when you first take your A and your B. And you can get Part D by signing up for a standalone drug plan, which is just Part D coverage. It's through a private company, and you'd have a separate card for that coverage. That's a standalone Part D plan. And I put up some of the acronyms that are commonly associated with these plans because you'll see them in Medicare publications. So this PDP stands simply for Prescription Drug Plan, meaning there's no medical coverage involved in a PDP. The other way a person can get drug coverage is through a Medicare Advantage plan. Most of our Medicare Advantage plans do have drug coverage, and sometimes you'll see the abbreviation MA for Medicare Advantage, and then PD for prescription drug. And there are some standardization among the plans that are Part D, that because they are all contracted with Medicare, there are things they all must have. There is a standard level of coverage, but what they can differ in is what makes sometimes the decision complex of which drug plan should I have. And it's because they will cover drugs differently. They'll cover drugs differently and at different pricings. So this combination of, is my drug covered and at what price, is part of what drives people towards their decisions. And it's certainly what we're setting out to help people on when we help people during open enrollment, is finding that right combination of how a plan covers your drugs, but at the lowest possible price to get the best match on which drug plan is your best for a calendar year. The plans can also differ in what they call a benefit structure, and you hear the word tiers associated with insurance. They place our medications in tiers. So every insurance company will put a drug in a different tier. Sometimes the most common generic drugs are always tier 1, the lowest cost possible amongst plans, but you'll have tier 2s and tier 3, tier 4, tier 5, even tier 6. So there's a lot of tiers, so meaning a lot of variation in price points among plans, and there's no assumption that a tier 2 drug in one plan is a tier 2 drug in another plan. It's quite a variation. And as we mentioned, there are costs most certainly for the different drugs. And so moving on, kind of in our general overview here about Medigap. Medigap is also private health insurance, and it's designed to supplement original Medicare Part A and B. And you hear the term Medigap sometimes, but it's also very commonly called supplement, and those are interchangeable words. So if someone says, I have a Medicare supplement, they could easily have said, I have a Medigap plan. It means exactly the same thing. And their job, the Medigap plans, are truly to fill in the gaps for original Medicare. Basically, things that are left over after Medicare pays what it's going to pay. The deductibles for Part A and B left over after Medicare pays. Medigap plans can pay some or all of those deductibles. The coinsurance, when they mean coinsurance, they're generally talking about if Medicare Part B is paying 80% on all of your outpatient services, which it does, then a Medigap plan is indeed paying the 20% left over. So that's how it pairs up. And then there's different co-payments that plans can cover related to Medigap. But and of course, it's sold by private companies, but there's choices. And that's, again, what makes it complex, because there's not just one Medigap plan. And technically, there are 10 different choices in terms of Medigap, and they're called with alphabet letters. And this is where we get more A's and B's and C's and D's. But we also get F, G, K, L, M, and N. And it's confusing, especially when there's two sets of A, B, C, D. But technically, what's going on is when you have your Medicare Part A and Part B and Part D, that is part. Those are parts of Medicare. When you have a supplement, those names like alphabet letter A is Plan A or Plan N or Plan G. So it's the term part when it's the basic Medicare, and plan when it's a Medigap or supplement. But it's confusing, and many of us feel like they could have come up with a better name for a supplement than more duplicating alphabet letters. But it is, as it has been for many, many years, and can be a source of confusion. Yeah. And to have any kind of Medigap plan, you have to have your A and your B. But once you got your A and your B and you're making this choice, there's some small variations of what one plan can cover versus another plan. There's a few rules about buying Medigap plans. So there's a particular special opportunity to buy Medigap when someone is both age 65 and has begun their Part A and Part B. You have a 6-month window of time in which you can buy any Medigap plan sold in your state as a guaranteed right to purchase it, meaning you don't have to answer medical questions or go through medical underwriting in order to get the supplement approved. You may pick any plan and get the preferred rate, but the deal is it's only a 6-month window of time and it happens once in your life. So the 6-month window happens once someone's past the age or reached the age of 65, but it's when technically their Part B as in boy also starts. And the reason that's not just when Medicare A starts, it's the B because so many people are working past age 65 and they might go ahead and take their Part A at 65, but they are still working and have group employer health insurance. And so at the point where they decide to retire, let's say they retired at age 70, they are very likely just then picking up their Part B. And that's the right way to pair it to keep your costs down. You pay for your employer insurance. You don't need Part B as in boy. Then when you retire and drop your health insurance to your employer, you get your B. Now, it's when that B starts, so this could be age 70, that the 6-month window of time that the guaranteed right of issue starts. So that's the technical rule of when someone can buy a plan without medical questions. So what that means for everyone else who's had Medicare for a while, they're not just beginning Medicare or beginning Part B, that once you've passed the window of time of this guaranteed issue, then you can apply for a supplement, but there will be medical questions and medical underwriting. And the great thing is you can apply for a supplement any time of the year. It actually has nothing to do with open enrollment that we're in right now. Open enrollment in the fall only has to do with Part D and Medicare Advantage and not a supplement. So people that try to act and enroll or apply to a supplement during this time of year, they are welcome to do it, but they have medical questions and they have to answer the set of questions. The company takes those to a medical underwriter and they literally decide if they will accept someone. So there's no guarantee to be accepted. People certainly are denied coverage when they apply if their medical conditions are such that the company doesn't want to provide coverage. So that's always an issue for people, is once they've passed their initial 6-month enrollment period, is can I ever get a supplement in the future if they never had one to begin with? There's not a guarantee, and there are people who cannot pick one up later because of certain medical conditions, diagnoses, medications. And then when people have a supplement that maybe they picked up at the beginning of starting their Medicare and they wish to change it because the price is going up, well, there's no guarantee to be able to change it. You can try to change it, you can apply to change it, and then the company will decide based on medical criteria, diagnoses, medications, whether they will write another policy. Now, the good thing is if someone had a policy and they were just simply trying to get another policy to see if they could lower their premium, the company can't take away their original policy just because they're applying for a new policy. Sure, they could get denied for the new policy, but they can't be dropped or charged more for the current policy. So there's definitely a consumer protection of the policy you have there. But most of these policies do go up based on age. That's the common way that happens. And they get more pricey as someone ages down the road. And that is the biggest complaint I hear about supplements. Otherwise, they pay very well, very comprehensively. There's little out of pocket when someone chooses to have a supplement, but the con to that is the premium that you would pay to have it. And we're talking, if someone is asking me, well, give me an idea of what I pay for a 65-year-old female, we're at right about $100 a month right now for what would be the most comprehensive supplement someone could buy nowadays. About $100 a month, 65-year-old female, and it goes up from there. It's not uncommon at all to hear someone talk to me and they're approaching 80 years old. They're likely paying over $200 a month for their supplement. So that's also within the realm of normal, because of course the insurance companies rate age as a factor that it will cost them more to cover us as we age. So that is a fact of having a supplement. And there are, like so many things, exceptions to every rule with Medicare. So there are a few exceptions to where someone can get a supplement outside of that very first 6-month window when they first started Medicare. One exception right off the top of my head I could think of would be someone who moves to our area, maybe from another state, and they might have had a type of insurance that was sold in their state, and it flat out ended. Their medical coverage ended when they moved to Virginia. Well, that actually opens up a guaranteed right to get a supplement in the situation I'm describing, where they lost their medical coverage. It was a Medicare Advantage plan, which I'll talk about more in a minute. And they have 60 days, not 6 months, but 60 days in which they can get a new Medicare Advantage plan or a supplement if they wanted to buy a supplement. So those situations do occur, and we help people. That's part of the counseling that we do at VICAP, at VPAS, is helping people through situations when they move. What kind of opportunities are open to you now that you've had to move? What can I do? What choices can I make? How much do they cost? We have that kind of information for people. So Medicare Advantage. So this is that other kind of Medicare that they refer to as Part C sometimes, but it's most commonly referred to as Medicare Advantage, where it's the bundled A and B and usually D drug coverage. So these are also contracts run by private companies. When people have a Medicare Advantage plan, they're enrolling with a private company. Humana, United Healthcare, Aetna, Anthem. You have a card from that company. It's approved by Medicare. It is a legitimate contract. It's available to anyone with Medicare. And you still have Medicare with all the rights and protections and appeal opportunities. It's Part A and B services are what Medicare Advantage plans cover on, and of course, usually the D. Most areas have some Medicare Advantage plans without Part D coverage, but it's not as common, and it can be problematic because if someone enrolls to a Medicare Advantage plan without drug coverage included, usually they cannot pick up drug coverage otherwise. You can't get one of those standalone drug plans and a Medicare Advantage plan without drug coverage. It's just usually the Medicare rules state you can't do both. You want Medicare Advantage, you got to get one with the drug coverage, is how the rule usually works for people. Who would want one without drug coverage? It is usually the best fit for veterans who are enrolled at the VA and are actively receiving their medications through VA. They often just don't need or want a Part D drug plan because they're perfectly fulfilled with their medications. So sometimes they'll want one of these Medicare Advantage plans that don't have drug coverage, and they're about the only people that fits for. Some more information about Medicare Advantage. How it works is that Medicare will pay a fixed amount for each member's coverage each month. So a lot of people actually think, oh, I don't have to pay my Medicare Part B premium for Medicare if I get a Medicare Advantage plan. Well, you absolutely do have to pay your Part B premium. One, you have to have A and B to get one. And they do require payment of the Part B premium. And so basically what's happening is Medicare's paying a likened sum of money, much like you pay your Part B premium. A sum of money like that is passed over monthly to your plan of choice, and they use that sum to manage each member's care. So they're getting this money from Medicare to manage every member. And that's how they can do what they do, often without charging a premium. We're going to talk about that a little bit more, but there's plenty of plans that say, hey, we have no premium. Well, they're getting monthly monies to cover that member. So Medicare Advantage plans can absolutely charge different out-of-pocket costs than a person would pay on original Medicare. Sometimes it's lower, sometimes it's higher than what a person would pay with their red, white, and blue card. But there's a few services that are fixed amounts that the Medicare Advantage plan cannot charge more for. And these services are chemotherapy, dialysis, and skilled nursing facility care. So that means Medicare is required to pay its standardized amount, and the plan can't charge more than Medicare would normally charge for the leftover out of pocket, which is like for chemotherapy and dialysis, Medicare has an 80% payment rate. And so even a Medicare Advantage plan, they got to stay at 20% as the patient pay amount. They can't make the patient pay more than 20%. That's an example. One of the biggest, most core benefits of a Medicare Advantage plan is something called a maximum out-of-pocket limit. And that would be the yearly amount of Part A and Part B services that a person incurs in costs for themselves all year. Basically, their co-payments and co-insurance. Part B, Part A services that you would have all year long, almost everything has a co-payment. Each plan has a whole book of what their co-payments every year are for all the services that you could possibly have. So that's set up, and so as you proceed through the year, you're paying your co-payments. You pay your co-payment to the primary care doctor, pay a co-payment to specialists, to diagnostic tests, any kind of outpatient procedures, hospital stays, and all of those co-payments will be tallied towards the maximum out-of-pocket limit. And if someone actually reached their limit, that means that they, the patient, have no more out-of-pocket costs. Their costs drop to zero for the rest of the calendar year. Now, that is for just Part A and Part B services. Drugs are not at all included in the maximum out-of-pocket limit. Drugs as in outpatient, self-administered drugs, things you would go to the pharmacy and pick up. Those are Part D drug items. So just to be clear, those costs are not tallied toward the maximum out-of-pocket limit. And if someone reached it, their A and B services are zero, but not their drugs. Now, the drugs that can be included in a maximum out-of-pocket there are some medications that are charged to Part B as in boy. And these are medications that are given in a clinical setting. Say someone goes to the outpatient center of their hospital to get a rheumatoid arthritis drug. Some of these newer, more specialty medications that are given as injections or infusions are done in a clinical setting. Those, by definition, actually come under Part B as in boy. They're very expensive medications, so Medicare is going to pay 80% on them. And the usual copay is about 20%, even on a Medicare Advantage plan. It's pretty typical. So that's an example of that 20% toward the cost of the infusion drug. That's going towards the maximum out of pocket. And if someone reached that, then it would drop to zero. Another big ticket cost-wise item would be chemotherapy cost, 20% being tallied toward that maximum out of pocket. Radiation therapy. So those costs that a patient is paying is going, at least there is a limit to it at the end of the year that you wouldn't go over. Now, how much maximum each plan has does vary between the plan. The lowest in our area hovers about $3,400 for the year. So that's about the lowest, $3,400. And we have a plan next year that's going to be as high as $12,000. So it's quite a variation in what we would help guide people on when they're looking at, maybe they want a Medicare Advantage plan, they already have one, they're looking at choosing another one. That maximum out of pocket is a big deal. Perhaps if everything else is pretty equal, but one plan says it's $7,000 and the other one says it's $3,500, well, that might be enough to make the decision right there to cut your total expected medical costs in half from $7,000 to $3,500. So that can matter a lot in the choice of a Medicare Advantage plan. Of course, as we know from marketing and ads, that Medicare Advantage plans like to tout that they have dental and vision and fitness, and most of them in our area do. It's not a lot of a benefit, but it is some, and their point would be, we have this dental, whereas Medicare usually doesn't cover dental. And if Medicare doesn't cover it, a supplement doesn't cover it. So you've got that as kind of like a carrot dangling of the different add-on benefits or extra benefits that can be really important to people as they're choosing a Medicare Advantage plan. So we're helping to guide people in how much dental does a plan have. So we'll look that up and help guide one choice of a plan to another. Another way these Medicare Advantage plans work is that they are different for each geographic area. When you hear about, look up your zip code, it does matter what your zip code is. It does, because different zip codes will have different choices of plans that basically the company has contracted in our service area. Like this area here, thankfully between Stanton and Augusta and Waynesboro, we have no difference in our plans in those close by zip codes. But Harrisonburg and Waynesboro have some slightly different plan choices, and it's not that far away. So the zip code does indeed matter. And we have about 22 different plans available in our zip code. So still a lot of choices. One of the big deals is the network of providers for Medicare Advantage plans. That's something that's going to be different amongst every company that has one of these plans. And we have to make sure when someone wants a particular plan that their doctors, their providers are within this plan's network. Because if you're not within the plan's network, you could have zero coverage. If you went to a provider that wasn't in network and your plan was an HMO, the plan is not obligated to cover for the service at all. Some of these Medicare Advantage plans are PPOs, and that means preferred provider organization. So that means that they allow you to see out-of-network providers, but you usually are paying more in some way. So that the privilege is that, okay, you can use both in-network providers and out-of-network providers, but if indeed you do use out-of-network, it's usually a little bit more in co-insurance. And then finally, here, plans have different rules that are in play for how you get services, and these rules change each year. These are things like prior authorizations or pre-approvals for services. It's pretty common with original Medicare not to have a need to get a diagnostic test or procedure pre-approved, but it's more common to have that happening with a Medicare Advantage plan. So a big part of what we're doing these days in our counseling is helping people choose between whether to go with original Medicare using the red, white, and blue card or choosing a Medicare Advantage plan. And an important note that we have for people is that if they are looking at having a Medigap or Medicare supplement, you have to choose original Medicare in order for that supplement to work. Supplements do not work with supplements do not work with Medicare Advantage plans. You can't put a supplement on a Medicare Advantage plan. You can only put a supplement on original or use of the red, white, and blue card. So I have a few slides that are doing a comparison between original Medicare and Medicare Advantage here. So one of the big draws at people keeping original Medicare, their red, white, and blue card, is that you can go to any doctor or hospital anywhere in the United States that takes Medicare. That if this provider is willing to bill Medicare, then you can go to any of those sorts of providers, which is most of our providers do take Medicare. So it's total freedom of choice there. Whereas with Medicare Advantage, you almost always have to worry about a plan's network. So locally, you can usually work real fine with a plan's network. It's usually affiliated with big hospital systems. For example, most all of our Medicare Advantage plans in our area will work with both Augusta Health and all of their affiliated providers and UVA and all of their affiliated providers. And a lot of people can happily work within those hospital systems and never have a problem with having a provider covered. But if they travel outside of their service area, then that's where it can get problematic with a Medicare Advantage plan. If you're traveling, seeing family, you're usually out of network then with a lot of these Medicare Advantage plans if you're traveling outside of our area. Emergency care is definitely always covered outside of your area if it's a true emergency, but something that's not a true emergency, but a medical need that crops up, then that's where it can be problematic and often total out of pocket for someone that has a Medicare Advantage plan because they're no longer within a provider network. So that's a big, big decision for people. Do I travel? Might I have a regular need for using my plan outside of my local service area? Referrals are another difference. Almost never when you have an original Medicare do you need a referral to see a specialist. But when you've got Medicare Advantage, it's very common to need a referral to see a specialist. Costs are different between original Medicare and Medicare Advantage plans. We've talked about this a little bit already. Original Medicare is pretty simple. For anything Part B, which is outpatient services, your doctors, urgent care, outpatient procedures, Medicare pays 80%, you pay 20% after you've met your deductible for the year. But with a Medicare Advantage plan, they're going to have a different copay for every service rendered. And each plan has different copays among the plans. So you have to look up each plan to see what the different copays are. It's part of the decision making. Part B, you have a premium for Part B. Either it comes right off the top of your Social Security check, or if you're not yet drawing Social Security, it's billed to you quarterly until the point where you draw it. And then if you have a Medicare Advantage plan, you also have that same Part B premium. So that's some likenesses there. Now, Medicare Advantage can also have a separate premium. They can. We have some of our plans in our area have a separate premium, but many of them are zero premium. It's just, again, looking amongst the choices. The limit to the out-of-pocket. So we talked about Medicare Advantage plans having as one of their big benefits a maximum out-of-pocket, the limit of what you personally would pay in a calendar year. Original Medicare does not have this limit built in. So if someone just had original Medicare and no other insurance, there's no limit as to what their 20% and all of their Medicare co-insurances would be throughout the year. But they can choose to put a supplement on the policy when they go on Medicare at the beginning. And if they choose that supplement, then that very much limits their out-of-pocket, and they end up with little to no medical bills when they choose a supplement to put on top of their original Medicare. So it's that purchase of an extra policy like a supplement is what limits the cost. So that's a big difference between plan with a maximum out-of-pocket where you can't buy a Medigap plan and original Medicare where you're going to have potentially a lot of out-of-pocket unless you buy a Medigap plan. And then the coverage. And the coverage is, it's all very workable. It's like anything, knowing the rules of your insurance. And Medicare is going to have very broad coverage of medically necessary services and supplies for medical and hospital items. But as we know, it doesn't cover dental care. It doesn't cover routine eye exams or glasses or routine physicals. But a Medicare Advantage plan will have that extra coverage for dental and glasses and vision in many of the plans. And it's something we seek and look out at each plan to see. Drug coverage, it's going to be very similar. You're going to have drug coverage in options either way, but if you have original Medicare, you're going to join a drug plan, whereas Medicare Advantage is going to be included in your plan. Now, the costs out of pocket of your drug coverage either way are not too terribly different. The drug coverage through a Medicare Advantage plan versus the drug coverage in a standalone plan, not terribly different. And they're standardized, was going to follow a lot of the same rules we're going to get to here in a moment, but not too different in out-of-pocket costs. Okay. A lot of people like me to describe the difference between Medicare Advantage and Medigap. So having a supplement versus having a Medicare Advantage plan. And we've talked about many of these already. There's some likenesses and some differences. The likenesses are you're getting these plans through a private company, whether it's a supplement or a Medicare Advantage plan. Another likeness, you got to have Part A and B to get it. So from there, they start to differ. Medigap plans are actually governed or have oversight by the state. The state licenses plans or companies to sell policies in each state. Whereas Medicare Advantage plans are federal, they're Medicare contracts, but they are contracted with providers in geographic areas. And that's what makes our choices of plans here in the Valley different than Richmond's choices because we each have different contracted providers that we're working with. Whereas a Medigap, the whole state of Virginia has access to the same Medigap policies. But even the price, though, can differ amongst the state. You can pay more of a premium for your Medigap policy in Northern Virginia than you do here in the Valley. So yes, the prices can vary by geographic area. And the coverage for Medigap simply pairs with what Medicare pays, and it pays the leftover cost. It pays some or all of the leftover cost, and that's why there's 10 different plans, because there's choices. There's a plan like Plan F that pays all of the leftover costs, and then there's a Plan N and a Plan B and a Plan A that have more leftover costs, but it's still pretty minimal what's left over. Whereas we talked about Medicare Advantage, where you have an out-of-pocket cost for every service rendered pretty much, but then there's a cap on it, a maximum out-of-pocket that might be $3,400, it might be $7,000, it might be $12,000. Provider networks, Medigap plans never have a provider network. They simply follow what Medicare does. So Medicare, you just have to have a provider that's enrolled in Medicare. So that's very broad. You don't have to worry about those networks. So with the Medigap, it just follows whatever Medicare makes the decision on. It doesn't matter about a provider network. But with Medicare Advantage, it most certainly matters what provider networks you're working with. Okay. And the marketing, just have to mention that because it's just so relentless. Everybody reports seeing the ads in the media, getting the phone calls, getting the marketing material in the mail, and it's almost always for a Medicare Advantage plan, almost always. And they try to be very sly and sneaky about what they're selling. So the point I wanted to bring up on this is that Medicare is recognizing the problems with the marketing. And they have had, in the past year, over 41,000 official complaints from Medicare beneficiaries about the marketing. And it's a huge increase than the kind of complaints they would have even 2 years ago. So they're recognizing something needs to be done, and they are actually invoking some new rules and regulations that are not starting yet. But come next year, about October of next year, there'll be a little bit more stricter marketing rules that are coming into play. Thank goodness. It's a step in the right direction. Things like recording the calls. Important if someone files a complaint to go back and hear the language that the marketing agent was using. So that's important. They're also requiring a disclaimer to be made in the first minute of the call that has to be very specific wording read to the individual that's the beneficiary on the phone by a marketer. So it is a step in the right direction of helping a beneficiary understand this is not just my plan trying to give me an update. It's a marketing call. I'm about to be connected to an agent that's getting ready to enroll me to a plan, because that has not always been made so clear. More clarity there, more understanding. That's the hope, at least. So again, we're in Medicare open enrollment. It started last week, technically October the 15th of every year, and it goes to December the 7th. And it is a time when you can freely change your Medicare Advantage plan or Part D drug plan. You can change it actually several times during that period. So people that change it once, maybe early on, and they actually have a maybe a big time change in medication occur in November, they can actually go in and make another change. As long as it's done before midnight on December 7th, you can make a change. The last one in wins. So the last change that's made is the one that sticks. And the start of new coverage is always January 1st during this time. And of course, this is our busy season here at VPAS, and we have a lot of counselors available to help people. We want people to call us and have us review their health and drug coverage. Do you need to make changes? And we're helping people identify whether they can save money by changing to a different drug plan, because it can be wildly different from year to year as to the number of plans offered and how they cover. And it can really benefit people to take a few minutes and review the choices, and perhaps money savings can be had. It's not unusual for us to save some people a couple $1,000s by changing plans. So it's a very gratifying part of what we do. I do have to mention this second open enrollment period that happens. So a lot of people aren't real clear that this exists, but it's called the Medicare Advantage Plan open enrollment period, and it starts in January, and it goes to March 31st. So for this open enrollment period, it's only for people who enter the year in a Medicare Advantage plan. So it's for folks who already have a plan, and they desire then, after the year starts, to make a change in their plan. So perhaps they enrolled into one plan, they started using their new Medicare Advantage plan in January and realized it actually didn't cover the doctors that they used, that their doctors were out of network for the plan. So if that's the case, they have the opportunity in January to make a change to either a new plan or completely drop the thing and have no Medicare Advantage plan. And they can go back to using their red, white, and blue card and pick up drug coverage. Also, if their plan that they're dropping has drug coverage, they're allowed to pick up a standalone drug plan. And that would be effective the first day of the following month. So February 1st in my example. I like to think of it as perhaps a buyer's remorse period for people who are entering the year with Medicare Advantage. They're trying it out for that first quarter of the year. And if there are problems, they have that chance to change it and get out of it if they were, maybe it's the first time they've ever tried one. So that's an important time frame. Then we, of course, help people during that time as well. The thing you can't do then is you can't just switch up a drug plan. So you only get one time a year if you just have a standalone drug plan to change it, and that would be now during the fall open enrollment. So the first quarter of the year, not for simply changing a drug plan, and not for getting in a plan for the first time if you've never ever had drug coverage. All right, so it's a good time of year to look ahead for the new year and some of the changes that have occurred. This particular upcoming calendar year in 2023 has seen a few more changes than we usually have seen when we're coming into a new calendar year. So I'm going to be highlighting some of the changes here. The one thing that we know already that we don't usually know actually at this time of year is what our Part B premium is going to be. Sometimes it's not till November, but they released that quite early this year, and it actually is decreasing, which is unprecedented. Usually a premium goes up every year, and last year it went up a lot, but this time in 2023, our Part B premium is going down to $164.90, a decrease of $5.20. The Part B deductible is also going down to $226 next year, That's decreasing $7. So what happened is about a year or so ago, they had projected ahead in spending for a new Alzheimer's drug called Aduhelm. Well, as it turns out, as this year has played out, lower than projected spending occurred both on the cost of the drug and other Part B items and services. So there is some larger reserves in the Part B account of the Medicare Trust Fund. And decision was made to use the surplus to reduce the Part B premiums and deductibles. So this slide illustrates some of the changes in Part D drug. So I have this slide and the next slide, which is going to show this information in two different ways. This is a graph form, and then I have an example because it is a fairly complex system, this whole Part D drug business. So Part D still has a deductible in most plans, and the deductible, yes, does typically change every year, but this deductible did go up. Unlike the B boy, this drug deductible went up, and it went up to $505 for the year. Most of our drug plans have that $505 deductible. Once someone has reached that deductible, they're in what's called the initial coverage level, and that would be considered the benefit price, the good price of the drug. You might pay $1 a month on some of your basic generic drugs. Some people pay $0 copay on some of their drugs then. If you take a more expensive brand name, it might be $45 a month. So that's during this initial coverage level. But as a person spends their drugs, spends their money buying medications all year long, the full cost of the drug is tallied all year, not just what they pay, but as the graph shows, blue is what the consumer is paying. The consumer is paying what they're calling an average of 25% of the cost of the drug. The plan is paying an average of 75%. So it's both things together, or you could say it the full cost of the drug that's being tallied toward getting a person into the coverage gap, what they used to call the donut hole. So the coverage gap has technically closed 2 years ago. It used to be much worse than it is now. When someone does reach the coverage gap, that means that they have had $4,660 worth of drugs based on the full cost of the drug, $4,660. And if someone arrives to that point, then their drugs must be priced at 25%. So brand names are at 25%, generics are at 25%. So what's actually happening during what would be the initial coverage level or good price, 25% might be the cost of some drugs, but in reality, a lot of companies are charging much less than 25%. You might be paying 5% or 10% of the cost of the drug during the good phase, the initial coverage level. And then once you reach the coverage gap, it would go to a fixed 25% copayment for the patient or the consumer. And just to kind of finish out this phase, your costs continue to be tally of what you're paying all year long, even through the coverage gap. And when someone has laid out $7,400 in drug costs, then they can reach catastrophic coverage and their price point drops to 5%. So what was 25% drops to 5%. So that's a relief in prices. And that's not based on the full cost of the drug, the $7,400. It's based on what you pay out. And also, more importantly, this green bar that's called the drug manufacturer discount. So it's part of the rules and regulations with Medicare Part D is that with a brand name drug, only a brand name drug, the manufacturer of that drug is required to put forth a 70% discount for Medicare Part D contracts. And that 70% gets to be applied towards helping someone come out of the coverage gap and into catastrophic. So really, it's what the consumer pays and what the manufacturer pays. And of course, the cost of the generics, but the consumer pays too, is what's getting someone to catastrophic here. All right. Another way to lay this out, sometimes hearing a more realistic scenario illustrates it better. So if Miss Smith had a selection of drugs and we need to describe how she moved through the year, if I am going to make up a few drugs for her, I'm going to say she takes Eliquis. Her doctor prescribes brand name Eliquis for her as a blood thinner. It's in the class of drugs of a blood thinner. It is only name brand. And let's say she takes a generic blood pressure too. So at the beginning of the year, she's going to pay full cost for her drugs. That's how a deductible works in most of these plans. So I looked up yesterday just to have some accurate numbers. The full cost of Eliquis is hovering around $600 a month now in full cost, right around $600. So the first month, she's going to meet her deductible. So the deductible stops at $505. She meets that deductible the first month. So the next month she gets Eliquis. She's in her initial coverage phase, her benefit price. It's pretty common to see a drug like Eliquis be about $45 in the initial coverage phase. It's fairly typical of how plans will provide pricing for a brand name drug. Now her lisinopril might be $1. It might be $0. So she's cooking along pretty good, paying what are really very reasonable prices for a brand name drug and a generic. But every time she fills those drugs, each fill of Eliquis, where she pays $45 at the drug counter, $600 is being tallied every month towards the coverage gap, the full cost of the drug. So $600 month after month after month. So she will reach $4,660 worth of drugs before the year is over. She will reach the coverage gap. And once she arrives there, then her Eliquis goes to 25%. No matter what plan she's in, 25%. So it will go to about $150. And she'll pay $150 a month for Eliquis during the coverage gap for the rest of the calendar year. If that's all she took, she would not get out of the coverage gap. The year would end before she put out $7,400 worth. But if she had other medications in the mix, every medication you take is going to get tallied towards the $4,660. So of course we could meet people who are on Eliquis and maybe some insulin or other blood sugar control medications. And every time they fill a drug, it could be $400 to $600 in full cost for every one of these brand name drugs they're filling. They might get to the coverage gap in the summer, say July, and then they start paying 25%. But the brand name manufacturer discount is providing 70% worth to help them get out of the coverage gap. And if they got out of the coverage gap before the year ended, then that drug would drop to just 5% cost. So that's a typical year and how that would play out. Those are kind of real numbers. And so now on to the Inflation Reduction Act, they call the IRA, that did become law August the 16th of 2022. And the reason I'm bringing it up is that it has some significant impacts on prescription drug costs built into it. So the Centers for Medicare and Medicaid Services, or CMS, is charged with implementing these parts of the law, and they're currently working on it related to prescription drug and health costs. So we're going to highlight some of these. This particular slide gives you a summary timeline of different parts of this law that are to be implemented, both in 2023 and 2024, 25, 26. It does go on. They actually have a layout till, I think it's 2029. But the issue could be if there is an administration change here in this timeline, then parts down the road in the timeline could change. There could affect the law and change what's going to happen beyond 2026. So we're just kind of looking close in for now to some more of the sure things that they expect to happen. So I'll elaborate on these a little bit. So starting in January 2023, one of the most significant things coming out of this IRA is the cap on insulin for Medicare Part D plans. It's a big deal for people who take insulin. And what's happening here is no matter what insulin that they take, no matter what plan, I should say that a different way, no matter what plan they have, the insulin's covered by that plan must be $35 a month. And that's the law. And that's a huge difference. A little more on that in a minute. But also importantly, vaccines that come under our Part D plan are going to be zero copay. And that can include the shingles, which if you've had a shingles shot under Part D, you pay several $100s to get your series of 2 shingle shots. So that will be zero starting next year. And then they've also set in a provision to limit drug price increases. And if a drug company is rising their drug prices faster than inflation, they have to pay a rebate to Medicare. And there's a financial penalty for non-compliance. So they're still working out the details on that. So I don't know anything further than that particular statement of the provision. But I'll go into some more details on some of these items. Looking ahead to 2024, there continues to be some significant changes. We talked about the coverage gap and catastrophic coverage under Part D a few minutes ago. Right now, you still pay 5% of the cost of a drug when you get to catastrophic. Oh, I'm so sorry. I pushed that button too fast. Let me go back. Hey, there we go. But in 2024, there's no longer going to be a 5% coinsurance. There will be zero cost when someone has expensive enough drugs that they come through the coverage gap and reach catastrophic coverage. At least those drugs will drop to zero copay. So that's an important change coming in 2024. People that are eligible for extra help, also called the low-income subsidy benefit, there's a little bit easier eligibility involved with that. The government uses the number 150% of the federal poverty level. And so that's about $1,700 for an individual and about $2,200 for a married couple, just roughly going on my memory. So it's a set eligibility number that if someone is under that income and they're under a resource limit, they can be eligible for extra help. That's how it stands right now. But what's getting simplified in 2024 is there's this complexity of having full extra help and partial extra help. And they're eliminating the partial extra help. So it's all a good thing. And people are going to have an expanded access to help with their drug premiums, help with the cost of medications during deductibles, lower co-payments. So people that have the lower incomes will continue and even have expanded low income costs. It's a help, and that applies to Part D plans. And then as far as Part D premiums, the provisions in the law say that the premium cannot increase more than 6% per year through the years 2024 to 2029. 2025 brings a significant change in that it caps a beneficiary's out-of-pocket Part D costs at $2,000 per year. That's huge. Part D, it's a huge benefit. Part D has never had a cap on beneficiary costs. So you pay what you pay. It doesn't matter how much you add up to in a year. It never had a limit. So they're saying in 2025, at least there's a limit in how much you pay out of pocket. And then they've chosen the number 2,000. So that's a huge help to people with drug costs. So that's coming in a couple years. And then as far as this will go into 2026, this is starting the negotiation with drug manufacturers for the price of Part D and Part B as in boy drugs. That will start then. A little more about the vaccines. This is the benefit starting in 3 months in January. If anyone needs to have a vaccine, it should be a zero copay. Many vaccines are covered by Medicare Part D. So if it's a covered Part D drug vaccine, no matter what plan you have, it'll be zero copay. So shingles is a broad example, but also a tetanus shot is another example. And vaccines are confusing because you can get them in different you can get them charged to different parts of Medicare when you get them for different reasons. The tetanus is a good example. If you get a tetanus shot because you've stepped on a rusty nail, that is in response to a medical condition. That's Part B boy. It's charged to Part B. And so Medicare would pay it at 80%. And if you had a supplement, the supplement would pay it at 20%. Or your Medicare Advantage plan would cover it. So starting next year, a tetanus shot that's charged to Part D drug would be given to you simply because it's been 10 years since you had your tetanus shot, and it's more like a preventive. So if you get a tetanus for that reason, it's D drug, but zero. So that's a good thing. All right, a little bit more about the insulin because it's such a big deal for next year. And as we discussed, no matter what Part D or Medicare Advantage plan you might have, they must charge only $35 a month. Now that's a max. They can charge less than $35 a month, but not more. And that's per month per insulin. If there's a deductible in the plan, the deductible does not apply to the insulin. So it's the $35 copay no matter what phase of drug coverage you're in. You don't have that applied towards the deductible. If you get in the coverage gap, it's still $35. So the deal is still that you have to check to see if a plan covers the insulin you take. Plans are not required to have what's called an open formulary, meaning, oh, y'all have to cover every insulin that's made, that they're not required to do that. They still get to pick and choose which insulins they cover. They have to cover insulin, but they can pick and choose which brands for the different classes of insulin. So that's where it can get tricky is, you're going to pay 35 bucks, but to make sure the plan that either you're getting ready to enroll in or already have covers the actual insulin brand or type that you're going to be taking. And we're prepared to help people match that up, knowing, all right, price is set, but actually we might be able to find a lower price than $35. Some companies, Part D plans are charging less than 35. That's one thing we're checking. The other thing is the formulary, making sure it's covered by your plan. Here's a note about insulin that gets charged to Part B as in boy. Because of Medicare rules, if you have a drug that comes through a piece of medical equipment, durable medical equipment, DME, then that drug gets charged to Part B as in boy instead of D as in drug. So people that use insulin through an insulin pump, that insulin gets charged to Part B boy. It's still going to be $35, but it doesn't take effect until July 1 instead of January 1. For Part D drug, insulin was January 1. For Part B boy, it's July 1. And this insulin pump area has become rather gray because now you can get insulin through a pump, but it's a disposable pump. And insulin through a disposable pump, one of the big name brands is Omnipod. There's a ruling that that's actually under Part D. So this is a definition Medicare has made that Part D disposable pump insulin is going to be charged still to Part D, and that is effective January 1st. Just some shades of gray here, but it's part of our counseling sessions to help people make these decisions and know what they're going to pay. A point about another new thing coming. This was not in the IRA law, but it's just another ruling or regulation that Medicare has set. And Medicare has said that all drug plans have to have a real-time comparison tool for drugs starting January 1st. So this real-time benefit tool would be accessed through the drug plan's website, not the Medicare website, the drug plan's website. And that gives a beneficiary access to looking up a specific drug and to know, one, if it's covered right now, and at what tier and at what price and at what pharmacy. So that if you were going this afternoon and it was January, because it doesn't start till January, if it was January and you were going on a particular day to pick up your drug, you could look it up at home or on your phone and know, okay, I expect to pay X amount at the pharmacy counter going to this pharmacy on my plan. And so that provides some transparency, some pricing that's available and accurate for people that hasn't been so good over the years. So that's a very helpful tool for everyone to have. The Plan Finder is the tool that Medicare uses for beneficiaries to search for new plans. It is on the Medicare.gov website, www.medicare.gov. And it has the ability for someone to type in their medications and then search for plans in which it's giving you the cost of your drugs compared against all 24 drug plans and helping you sort through which is your best coverage, what's your lowest out-of-pocket cost. And we use this at VPAS in our counseling. We're using Medicare's tool just like beneficiaries use, because it's been the best way to choose a plan since Part D began in 2006. Hands down, it's unbiased, it's not operated by an insurance company, and it's calculating the math of how much your drugs cost against every plan and tells you the bottom line least expensive plan. And that's just proven to be the best way to choose a plan. And that's how we're guiding people in this choice. There's a way to log in with a Medicare account. We very much encourage people to set up Medicare accounts. It's pretty easy, easier than some other organizations' accounts. It's all based on your Medicare number. You have to plug in your Medicare number. your zip code, your date of birth, your name, and you set up an account with a username of your choosing, which can be an email, and you set up a password and you choose a secret question. And once you're logged in, you're able to see really great details about your current plan. It saves medication lists for you so that you can have a built-up medication list that you can edit and add to, detract from over time. And that's very helpful to be able to go in and say, oh, I want to look up the cost of my medication. But your drug list is already available. You don't have to keep typing in drugs. It's there and ready. You can add in different pharmacies, because it is very true that a different pharmacy will affect the price of your drugs. Every one of those 24 plans uses a different set of preferred pharmacies. So pharmacy matters big time, and it's different amongst all the plans. Like some people will come in and say, well, I know Walmart's always the cheapest. No, it's not. It all depends on whether a certain plan has a contract with Walmart, and not every one of them does. Walmart sometimes is not the preferred pharmacy with a particular company. It might be Kroger and CVS, whereas another company or two or three does have Walmart. So it really depends on the plan. And this is another thing we find on the plan finder, and it's loaded into your account, just making it even that much easier to determine best coverage and best pricing. A little note about insulin this year for anyone that takes insulin and they're going through and looking up the cost of the drugs. When Medicare loads all of its costs up for open enrollment, it does it based on the costs that were submitted back in June of a calendar year. So June is when all of the companies submit what's called their annual bid. Medicare accepts, once it's accepted for an annual bid, those are the prices that company is going to work with for the coming year. The prices are loaded for all those thousands of categories of drugs into the plan finder. So prices for insulins were loaded based on those June prices. So what's happened is in August, the law was changed. So the insulin prices in Medicare's plan finder are wrong. And they don't have the ability, apparently, to change it. And so a pop-up message occurs that, hey, the price is wrong, but you will only pay a max of $35 a month. So it's just a heads up that, yeah, the insulin still might look like several $100s a month to fill insulin, because those were the prices loaded back in June. But the reality is the price paid in January is $35 a month. And so that's a big workaround that we've had to establish a procedure. Medicare came up with a procedure to help people like us who assist others in determining best cost. We have a workaround that we're prepared to help people pick the right plan, know your plan's going to cover the insulin, but factor in, okay, it's $35 or maybe $25, depending on the plan. So there's a workaround in place. And this is just a view of what it looks like if you're looking yourself and you see a plan that says, this actually says Lantus. Lantus is a type of insulin. It's a pen injector, and the little words here say not covered. So that's how the plan finder displays something that's not on their formulary or not covered. So in this case, if someone took Lantus and they were looking on whatever plan this was, their insulin would not be $35. It would be probably full cost because it doesn't cover insulin. So either they change insulin to the one that this plan does cover, because they have to cover insulin. They're just going to cover a different brand, a different drug manufacturer's version of it. It's one choice. Or since it's open enrollment, perhaps we're looking at another plan altogether that does cover Lantus, because actually the majority of plans do cover that particular type of insulin. So that's just the note that you would see. We're getting towards the end here. This is what it looks like when we compare plans, where we talked about that bottom line. So this is a shot of what it may look like if we were comparing 3 different plans. We have a WellCare plan, and we have 2 different SilverScript plans. So I realize it might be hard to see the numbers. We have a $9.60 plan. We have a $70.40 plan, and a $5.10 plan. This is a real person's drugs that I helped last week. I think there was an inhaler involved and several other medications, about 8 or 10 medications loaded on here. Anyway, out of all of these plans and the pharmacies, but she wanted to use either CVS or Walgreens. It was the only pharmacy she was willing to go to, CVS or Walgreens. So out of all these choices, the bottom line best coverage for her medicines at $1,484 actually fell with the $70 plan. And that's why you can't go by the cost of the premium to know if it's your best coverage. So for $70.40 a month, the bottom line of what she'd pay, both in premium and drug cost, was the lowest, and it was the lowest using CVS. If she went to Walgreens, it was about $500 a year more. Pharmacy matters. It's because Walgreens happened to not be a preferred pharmacy in this particular plan. CVS was. So if I was working with this person and she said, nope, I only want to use Walgreens. Well, with this set of numbers, we're probably choosing this WellCare Value Script plan at $9.60 because $1,799 is the lowest price for her medicines using Walgreens. So many variables. It's the drugs, it's the plans, it's the premiums, it's the pharmacy. But this is doing the math. And once you learn how to work with this, it's a tool that's so helpful. And sometimes a plan won't even work with a pharmacy. So this $5.10 plan, which is the least expensive plan in Virginia, the SilverScript Smart Saver, great, it's $5.10 a month. But if you really need to use Walgreens, it's not the plan for you, because it absolutely doesn't use Walgreens. But you would pay full cost for your drugs all the time at Walgreens. You wouldn't necessarily know that unless you were, able to look up this information. So it's just so interesting what you can find by taking a few minutes to check. Another way that we're looking at it is I can look within one plan. So this is one plan. It's a Cigna plan. This is another client's drugs from last week. She took 12 to 14 medications. And we put in 5 different pharmacies because let's see, how is it coming out? Who's the lowest cost? So for her, the lowest cost for any of these 5 pharmacies came to Kroger, $3,014. The lowest price in the same plan, getting the same drugs, but just looking at a different pharmacy. But interestingly, even the more independent pharmacy, Augusta Health Prescription Services, was only about $30 in the year more. And it was the second least expensive choice. And she was thrilled because she actually used Augusta Health Prescription Services. So for her, this was the choice. Use this plan with this pharmacy. Another thing it does here is it lays out when someone will meet their deductible. This is helping them plan for cost. So March of 2023, she's met the $505 deductible. And then by either July or August, depending on the pharmacy, she's entering the coverage gap because her drugs had pretty high costs. So she's entering it in the summer. Her brand name drugs will bump up in cost. And then the year will end before she would get out of the coverage gap. So it's helping someone plan for how their costs will change throughout the year. Very, very helpful. This slide, needymeds.org, is about basically patient assistance programs that are out there. Almost every brand name drug has a patient assistance program. This would be brand name drug. The drug manufacturer has set up a way for patients to be able to obtain the drug affordably when their insurance doesn't cover it well, or when they don't have insurance. That's what these programs are set up to do. And it's basically a finder of information where you type in the name of a drug here, and then it searches for it, and it tells you then the maker of that drug. In this case, I'm looking up Januvia, the blood sugar control. It's only brand name, has no generic, and Merck makes it. So Merck does have a patient assistance program. It'll give you their website and their phone number. So you always have that information, so you can call and look it up. And one of the points I wanted to make is this is not low income programs. Many of these programs will go up to around 400% of the federal poverty level. So using real numbers, the federal poverty level, that number is right about $1,100 for a single person. So 400% is 1,100 times 4, $4,400 a month is the income limit for a single person. So it goes up pretty high. For a married couple, it'll go up. The married couple number was about $1,500 a month. And so, likewise, it was about $60,000 a year for a married couple. So we always check this because sometimes people are surprised that their income might fall within the requirements. They often will have other requirements, and this doesn't always display that here. And we either look on their website, they're pretty clear about it on the website, or call them. But it's common for one of these patient assistance programs, when you have Part D, to say, will only help once you reach the coverage gap. That sometimes they might have the income limit, which is pretty high, but then only start helping you when you reach the coverage gap. So I'll find that criteria. Another criteria might be you have to prove that you've spent a certain amount of drugs in the year before they help you. Weirdly, a common number is $1,100 when I've looked it up. So once someone can show pharmacy receipts for $1,100 and their income's within the limit, they can start getting that drug for free. And when someone qualifies, it's almost always no charge. So they're fantastic programs. They all have an application to fill out. And almost always the doctor's office has a portion to fill out on the application too. But it's kind of like writing a prescription, their portion to fill out is. So some time and effort involved in filling the application out. But when you get it, it's no cost. And that way you don't have to fill that drug on your Medicare Part D plan. That's really significant. That brand name drug doesn't go on the plan, perhaps adding up towards the deductible and the coverage gap, depending on the program. It's very significant. And the last slide here is about the drug discount cards. This is GoodRx, Single Care. There's others out there. There's a lot of drug discount cards. They have their place. Importantly, you can't use it at the same time as your Part D plan. You can't put a discount card on your insurance. They definitely don't operate that way. But you can use it in place of your Part D plan if the discount card has a better price than your drug insurance plan does. And sometimes that happens with that. Usually it's only generic drugs that these help. A brand name drug, it's rare that these will give much of a discount on, but generic stuff, some people's plans, some generic medications can be put in higher tiers with higher co-payments. And just an example I looked up for someone last week, she had a bladder control medication. It was generic, but the plans don't cover those greatly, bladder control medications. So she was going to pay towards a deductible of around $114 a month to start getting the medications. So, I mean, right there, it's about 5 months of that before you reach the deductible, close to it. And then the drug was going to drop to about $35 after that. Well, she said, I am not going to take this drug if I have to pay $100 a month for it for several months. I can't do it. So we looked it up on GoodRx, and it happened to be $25 a month. And she said, I can do that. And so for her, she's just not going to fill that drug on her Part D plan. She's going to take it to, happen to be Martin's. It does depend on the pharmacy. Each pharmacy has a different price with these drug discount cards. So I printed her a coupon, and she'll take the coupon to Martin's and pay the lower price. But of course, you can show it on your phone. You can show the coupon on your phone. You can print out one of these GoodRx cards, but they can be a tool to use to try to find the lower copay. And you can definitely work with that with your plan. But that is the end. So thank you for your attentiveness. I appreciate that. And we are going to be able to take some questions here. And as I know it was a lot of information, but I am happy to go back to any of the slides, talk about anything again, or answer questions to elaborate on something a little bit more. Were there any questions chatted in?
No, I just asked.
Do you guys have any questions?
So I have.
Okay.
And
you still have the penalty. Indeed, it applies no matter which way you get it. May I say the question again? The question, just for those viewing it this way, does a Part D penalty apply even if you have your drug coverage through a Medicare Advantage plan? And the answer is yes, it does, because it's the alternative way of having Part D is through Medicare Advantage, and they still use the same rules about calculating and applying the penalty. Indeed, they do. But if a zero premium plan works, at least that's certainly a way to lower your overall premium intake. Yeah, good question. Yeah.
Joyce would like you to stand in front of the questions.
Okay.
Sorry, I didn't mean to throw my mouse still.
No, I can't tell what you can see all this.
I know, and you're blinding yourself like that.
Can you see my face?
Hold on, let me.
Shadows. Got a good shadow.
Yeah, real good shadow.
Great.
Yeah. So Marissa wants to know, is Silver Sneakers only through a Medicare Advantage plan?
Good. Usually that's the only way to find Silver Sneakers is through a Medicare Advantage plan, but we do have a couple of supplement companies that I'm aware of in our area that offer Silver Sneakers just as an add-on benefit when you sign up for their supplement. And the ones I'm aware of are Anthem and United Healthcare, which is an AARP plan. So Anthem and United Healthcare, that's much better.
Sorry, y'all.
Anthem and United Healthcare would have Silver Sneakers in Virginia here with their plans, as well as many Medicare Advantage plans have them. Yeah. Humana does. Yes, Humana is one that's had it for a long time. Yes. That's a good question.
So when like, I have Humana,
Okay,
so when I use their mail order pharmacy, their medicines, generic medicines, tier 1 and maybe tier 2.
they are.
They're free.
Tier 1 and Tier 2 medications are zero cost on Humana's mail order pharmacy. Correct.
So, but the original amount of that medication is being charged against that don't get into the donut hole.
Yes,
Okay.
that is the unfortunate reality,
Okay.
is the full cost of that medication is being tallied, refill and refill again towards the getting you into a coverage gap or donut hole. And yes, even though your cost might be zero, a person could reach the coverage gap if technically the full cost of the drugs were past 4,660. Yes, that is a fact. Yes.
Could you avoid that somehow by getting part of them, like, let's say, you can go to Walmart and get 3 months supply, not using your insurance
That is
for
correct.
$10 or
That is
$12
correct.
or whatever.
It's
it
a
is.
strategy that some people use when they are perhaps really close to getting to the coverage gap before the year ends. And it might make a difference of putting some of their medications somewhere else, like using the cash price at Walmart, or saying, I'm not going to charge it to my drug plan, I'm going to get it on Good RX, or any of the pharmacies that are doing really cash prices. So the drug is not charged to your drug plan, it's not being tallied to get you into the coverage gap. So yes, that can be a strategy.
Okay.
Indeed.
That's good to know.
Yeah, it is good to know that you have some leeway to work with your own costs and control it a little bit. Yeah, it is really good. Yeah, anything you want to ask?
On the Social Security statement that we get ever so often, it has my Medicare prescription drug and has the amount, which happens to be $11.70. Now, is that the whole that? And I didn't realize that I had the drug, but that is part of the drug thing.
Yes. So you have a line on your Social Security statement that
Yes.
states Part D premium and the
Right.
amount that's removed right off the top of your Social Security check, $11.70.
Right.
So that happens to be the current WellCare Value Script plan premium.
That's one I had.
Okay, yeah, that's your plan. So that is indeed a standalone Part D plan. It's going to change to $9.60 next
And I
year.
understand
Did you
too, it
see
was
that?
gonna drop. Yeah.
Yes.
And it's,
So if you do nothing, your premium will drop and a little bit less money would come out of your Social Security check for Part D. And I do want to mention that, it may be 50-50 as far as people that get their Part D premiums removed from their Social Security check versus electing to just pay their company directly. So when you enroll to a Part D plan, or change it and enroll to a new one, you get to make a decision each time about whether to take the premium from Part D, or that didn't make sense, whether to take the premium from your Social Security,
yeah.
or pay the Part D plan directly. And some people prefer to do that just so nothing more gets removed from their check.
Right.
Yeah.
Right.
Yeah.
That's what I was glad to see that. And I had one more thing that I was, I have, of course, Medicare, and I have Anthem Blue Cross Blue Shield as my supplement.
Okay.
And over and above that, and even one of those, I have dental. So I have Humana dental.
Okay.
And so the only thing that I guess, the only advantage that I would have with going with the advance would be the eye and hearing. Is that what I'm understanding? That's the only two things that I'm lacking.
The only two things that you're lacking in coverage is eye and hearing. And I can add that your current Medicare coverage does include medical coverage of the eye.
Yes, I do.
So your eye exams, that part that has to do with, if someone might have glaucoma or pre-glaucoma or diabetic concerns of the eye, those are charged to Medicare as medical diagnosis.
Well, actually, I have macular degeneration.
Macular
And
degeneration.
I take those horribly expensive shots every 5 weeks in each eye.
Okay, so
And they're covered, and that's with Medicare.
that's correct. And so it would be covered differently with a Medicare Advantage plan. If you went to receive your same macular degeneration, eye exams, and the shots with the medication,
Yeah.
and you had a Medicare Advantage plan, you would end up paying a copay for each of the shots. Yeah,
That's great, yeah.
even though they might provide $200 toward a pair of glasses and pay for the routine part of your eye exam, the other out-of-pocket costs would well exceed $200 towards a pair of glasses.
Yeah.
So it probably wouldn't come out ahead for you to switch to a Medicare Advantage plan when it comes down to how much out-of-pocket you would have
Right.
with those kind of conditions, indeed. Yeah.
Certainly appreciate your time.
Oh,
and
you're welcome.
energy.
Yeah,
Couldn't
yeah.
think you sit down and do anything else.
Oh,
You've been on your feet
it's
for
good.
couple
It's
of
good.
hours.
I appreciate your attentiveness and your questions and for being here. Thank you. Thank you. Any other questions? Okay. Okay. All right, we'll wrap this up then. And I can stay around if you have any personal questions too. Thank you guys for coming. Appreciate it.
All right, before people run away, can you do one more thing?
Good right, Amy.
No pressure, Amy.